Welcome to this high-yield explainer. Today, we're investigating one of the absolute most terrifying, high-stakes paradoxes in clinical medicine. We're talking about a condition where your body's own protective mechanisms turn entirely against themselves. It creates this biological wildfire that demands immediate, precise intervention. It's essentially a state of total systemic failure where the very system designed to save your life becomes the ultimate weapon taking it apart. Picture this. You're standing in the intensive care unit. Your patient is battling severe gram-negative sepsis. They're critically ill, but they've been stable. Suddenly, the alarms go off. And it's not just the vitals dropping. You look closely, and the patient is actively oozing blood from their IV sites, their gums, their mucous membranes. Blood is literally pooling on the sheets. They're hemorrhaging right in front of you, and they have absolutely no prior history of bleeding disorders whatsoever. This isn't just a slow trickle. We're talking about a sudden, catastrophic loss of hemostasis. Okay, let's dive into this. This specific clinical nightmare presents the ultimate forensic paradox of disseminated intravascular coagulation, or DIC. How is it physically possible for a patient to bleed to death precisely because their body is clotting way too much? On the surface, it makes absolutely zero sense. To understand this contradiction, we really have to look past the visible bleeding and zoom way down into the microscopic vascular environment, where an invisible war is being waged. So, we're shifting from the macro ICU picture to the microscopic level. The primary culprit behind all this chaos is tissue factor. Under normal, healthy circumstances, tissue factor is a transmembrane receptor that safely initiates coagulation only when a blood vessel gets injured. It acts as a local sentinel, it's confined, it's heavily controlled. But in DIC, severe endothelial damage, like the kind caused by the violent storm of inflammatory cytokines circulating in our septic ICU patient, while that forces a massive abnormal upregulation. The sentinel completely goes rogue. Tissue factor is released directly into the bloodstream in staggering amounts. In this highly volatile environment, tissue factor acts exactly like a match dropped in a totally dry forest. Instead of sparking a small, localized, helpful clot to just patch a single injury, it triggers a runaway biological wildfire. We aren't looking at localized hemostasis anymore. We are witnessing the catastrophic, unbridled, systemic activation of the entire coagulation cascade. The normal checks and balances, they are entirely blown away by the massive scale of the trigger. Let's move to how this builds and map out the runaway train of pathogenesis step by step. First, that severe underlying disease causes massive endothelial damage, releasing a huge surge of tissue factor. Second, this kicks off uninhibited systemic coagulation activation. Third, this wild activation forces the widespread formation of microthrombi, literally millions of tiny clots everywhere. Fourth, building these millions of tiny clots rapidly consumes the body's entire reserve of platelets and clotting factors. And finally, step 5, because those vital resources are now completely exhausted, the patient experiences severe, unstoppable bleeding from anywhere the skin or mucosa is broken. And this brilliantly illustrates what's happening at the cellular level. Imagine the microcirculation becoming completely choked with these clumps. You've got this microscopic mesh of tough fibrin strands and trapped platelets. Millions of these microthrombi are violently lodging themselves into the tiny, fragile blood vessels of the kidneys, the liver, and the brain. They act like microscopic concrete pouring into the plumbing, physically blocking arterial blood flow and driving rapid, irreversible multi-organ failure. The tissues are quite literally suffocating. But building that microscopic mesh comes at a devastating cost. This is the consumptive nature of the coagulopathy, and it is the absolute key to the paradox. Building that massive wildfire of microthrombi requires vast amounts of raw materials. It rapidly depletes the body's circulating platelets. It heavily depletes fibrinogen, frantically converting it all into cross-linked fibrin. It thoroughly exhausts essential clotting factors, like factor 13. And at the exact same time, the body's natural physiologic anticoagulants, like antithrombin, are totally overwhelmed and neutralized. The body has used up every single resource it has to form these abnormal clots, leaving absolutely nothing to stop the bleeding at the IV sites. So this brings us right back to our ICU patient, perfectly summarizing the ultimate dichotomy of this disease. On the inside, the patient is suffering from widespread microvascular thrombosis, leading directly to devastating ischemia and multi-organ failure. But on the outside, because every single clotting factor and platelet has been consumed by those internal clots, the patient is left entirely defenseless. This results in severe consumptive hemorrhage. That's the terrifying oozing from IV sites and the spreading purpura bruising the skin. They are bleeding because they have literally run out of the ingredients needed to stop bleeding. Now, if you're a medical student or a resident studying for your boards, you absolutely must know this exact consumptive profile. Let's strip away the noise. We're going to look at the absolute high-yield diagnostic markers you need to secure your scores. And honestly, more importantly, to quickly diagnose and save your patient in a real clinical setting. So, the crucial point is mastering the International Society on Thrombosis and Hemostasis, or ISTH-DIC scoring system. If we look at the typical overt DIC findings, what do we see? Platelets? Severely decreased due to massive consumption. Fibrin-related markers like D-dimer? Markedly elevated. Prothrombin time, or PT? Significantly prolonged, because the factors in the extrinsic and common pathways are just gone. And fibrinogen? Depleted and abnormally low. Every single lab value paints the picture of a system running entirely on empty. You need to hammer home these specific board buzzwords: elevated D-dimer, depleted fibrinogen, prolonged PT. The elevated D-dimer is an absolutely crucial concept to grasp deeply. D-dimers don't just magically appear. They are the direct biochemical result of plasmin aggressively attempting to break down the massive, catastrophic amounts of cross-linked fibrin that have formed throughout the patient's microvasculature. It's essentially the biochemical footprint of the body frantically trying to dissolve the microthrombi to restore blood flow. And hey, if a peripheral blood smear pops up on your exam, look immediately for the word schistocytes, because the microcirculation is crisscrossed with these tough, wire-like fibrin strand. Normal red blood cells are violently sheared and shredded as they're forced through this microscopic mesh under high arterial pressure. This creates fragmented, helmet-shaped red blood cells, or schistocytes, and it results in a severe microangiopathic hemolytic anemia. It's just a brutal physical destruction of the cells. Now, what's really interesting about these triggers is the sheer variety of things that can light this match. DIC is never a primary disease. It's always secondary to a massive systemic insult. Looking at the major clinical triggers for your exams, you absolutely must watch out for severe infections like gram-negative sepsis, major obstetric complications like placental abruption or amniotic fluid embolism, massive tissue trauma, and specific malignancies, most notably acute promyelocytic leukemia. Each of these overwhelming traumas shares the unique ability to indiscriminately flood the system with tissue factor. Which leaves us with a truly provocative clinical challenge. You're standing in the ICU. You know the pathophysiology. You've identified the depleted fibrinogen, the elevated D-dimers, and the sheared schistocytes. But if your patient is simultaneously suffering from catastrophic internal microclotting and life-threatening external bleeding, how exactly do you reverse the process? Do you give powerful anticoagulants to stop the clotting, or do you transfuse massive amounts of platelets to stop the bleeding? I highly encourage you to research the treatment protocols for DIC, because the answer requires treating the underlying cause first before the fire consumes everything. Thank you for joining me for this explainer. Keep questioning, keep learning, and I'll catch you next time.